Welcome, everyone, and thank you for joining us. My name is Lily Jelinas, Editor-in-Chief for American Nurse Today, the official journal of the American Nurses Association. I'll be serving as webinar moderator. Our topic today is making workforce management a priority, sharing strategies and best practices to drive results, presented by an esteemed panel of experts. We thank them for their time and valuable information. This educational program is brought to you by GE Healthcare. We thank them for their support. Our plan for today is discuss why it's important to manage workforce data, review a case study of successful implementation to achieve a data-driven workforce, describe how a system used a staffing system to achieve positive outcomes, identify next steps towards a data-driven workforce. It's my pleasure to introduce you to our panelists today. They are Jennifer Mensick, Danielle Bowie, Kathy Baker, and Carlene Kerfoot. Now let's begin. Welcome to Jennifer Mensick.
Thank you, Lily. And I'm Jennifer Mensick. I am the Division Director for Care Management at OHSU in Portland, Oregon, and we're going to talk about why you need to manage your workforce data today. So I always like to go back, quite often we hear from staff and managers that we need more. We need more staff, we need more people. But I always like to kind of step back and pause and say maybe what we need to do, and quite often for the health of our healthcare system in the United States, is to relook at what we have and manage our workforce that we currently have better. We cannot continue to hire more and more, and we need to relook at how we utilize individuals. Most people have heard that healthcare is 20% of our GDP, our gross domestic product. So spending more in healthcare really is taking away from other things. It's taking away from maybe the police force or your primary education system in your town, or new sidewalks and new roads. So we really need to say, okay, from a healthcare perspective, how can we, we're spending a lot of money, how can we get the best for what we're currently spending instead of spending more? And that is really going back to how do we manage our workforce better? And it's really hard, particularly in acute care settings, because we've got patients, and patients are not widgets. So it's not like we have people who come in an assembly line. We have a lot of complexity, but we can understand that complexity, and we can help match the complexity of our patients and our nurses. So we want to think from a workforce perspective. We want to think about staffing and what we're doing when we staff. And it really is looking at the American Nurses Association definition. It's taking the nurse staffing as a match of the RN expertise with the needs of the recipient of the nursing care services. And so part of workforce management is understanding the RN expertise you need and the RN expertise that you do have. Additionally, there's the scheduling component. So it's staffing and scheduling. And when we're looking at scheduling, it's looking at all the activities that your nurses are going to do during that day. And quite often we look at IVs and wound care and tasks or interventions, when we also need to be looking at assessment, evaluation, looking at the other components that do take time, and what kind of resources do we need to make sure we are able to get all of those. Do we have enough time to do discharge planning and education, and looking at our patient flow, which we'll talk about in a little bit further complex. So what we also need to do when we look at our workforce and understand what we need is looking at your unit's care delivery model, because when you have a schedule, whether it's on paper or it's in the computer system electronically, that is a depiction of your unit's care delivery model with your workforce. And so how well does that match what you think you want from a care delivery model, and how well does the nurses you have match your unit's care delivery model? So you want to look at staffing levels, you're looking at your acuity system, because Not all med-surg units are the same. Not all ICU units are the same. And so you really want to understand the unique complexities of your units in order to make sure you have the right workforce for your type of units. Recognizing the importance of all nursing care. Again, back to assessment and evaluation, the time that it takes to do those types of things in education. Looking at the staffing mix you need. What kind of model do you have, and what kind of model might you want so that you can help to manage that workforce when you have openings, that you're able to fill those gaps and or educate to the right needs of your organization. And then matching IT systems to the workflow of the nursing, and to be able to capture the data you need out of the system to help inform your workforce data appropriately. It's really easy, unfortunately, just to be able to hire nurses. Treat nurses the same. I need an RN. I have an RN leaving. Let's just hire somebody. We need to recognize, though, same is true for patients. Even though, again, you might have a med-surg patient or an ICU patient, not all patients are the same and not all nurses are the same. And so you really need to understand your data for your unit so that we can staff and hire and manage your workforce to match the patients that you have. That's really complex. But many organizations are getting great data to do that. We are in healthcare, we have so much data and so much information. We just lack sometimes the analytics and the ability and the time to kind of drill down and to be able to kind of pause and really look at the data in meaningful ways to give you the information you need. Because we have 1,000 things going on. So this is where if we really set up workforce management and looking at our data in a meaningful way up front, it's going to help really in the long run set us up for success and really give us, improve our satisfaction of our staff and improve patient care. One of the better ways to help do this and to start managing your workforce is through physician control. And sometimes people don't like that term. It's an industry standard for what people do use when they're looking at the number of FTEs and the types of FTEs they have. But this really is a good place to start, to look at what kind of nurses do I need? How many nurses do I have? What's their FTE level? So one nurse is not exactly one nurse because maybe they only work part-time. How many nursing assistants or other unlicensed assistants do you have? Are they certified? What kind of certifications do they have? So having kind of a large sheet that kind of shows you the FTEs and what they're doing really helps to inform you at a glance of the workforce you have. And it helps you to understand, too, who might be going on leave, who's on FMLA. You can kind of look ahead and be able to forecast as well on who you might need to replace with a traveling staff member, if it's short term, or if you need to maybe hire ahead. So position control gives you that types of information. Now, what also helps give you information that helps to inform position control on the number of staff that you do need to is patient flow. And a lot of the complexity of patient flow is what we create ourselves. It's really hard with natural variability to be able to predict when a natural disaster is going to happen, or maybe predict ahead of time how bad the flu season is going to be. But you have a lot of data in your organization to say, this is when bulk of our traumas come in. The emergency departments have this pretty well down. In some areas, most of the traumas happen rush hour in the evening time. And so they're able to staff appropriately. Now, if the EDs know that's when they're going to get a bulk of the trauma, how well are the ICUs and the surgical units working with the ED to help manage understanding the staffing levels that they need to go with the patient flow? We also, but medical, surgical, and other areas do also have that type of data historically, and understand physician and surgeon volumes. So there is trending that does occur to help understand the types of patient flow that an organization has, because that will help you understand, too, what kind of staff you need and where the staff need to be, so that you can help manage the peaks and the valleys on your unit so that you're not having wild swings in census. And that, that really is a staff satisfier too, because then you're able to schedule appropriately without a lot of low census or a lot of overtime when you're able to manage the variability that's going on in your organization. And this really all leads to when we don't manage workforce data and we don't understand how this affects staffing and scheduling, it leads to missed care. And unfortunately, some of the biggest reasons for missing care are unexpected rises in patient volume. We're not managing those peaks and valleys in the natural and artificial variability. We have poor personnel deployments. So we didn't understand or don't have position control kind of understood, and we don't understand the types of staff we need for the types of patients we have, and excessive workloads because your staff might be working short. So unfortunately, it leads to miscare, and this is a really bad dissatisfier, and it also takes a moral toll, an ethical and moral toll on staff when they leave feeling like they missed care, and they don't purposely miss it. There's just so much going on in a shift, especially when there's not enough nurses or the right types of nurses to get things done. And a lot of the research that does show that when people miscarry, these are the types of things that occur, or these are the types of nursing interventions that are missed. So assessments and interventions, ambulation, turning. And when we think about there is research that shows having more nurses decreases length of stay, and having more nurses actually brings revenue into your organization. It's because the nurses are able to do the care. There's less miscare, and we are able to get the patients better faster. So it all is really interconnected to how we manage our workforce, how we look at the flow of our patients and the flow of our organization, and how we deploy resources, and how it really does impact outcomes at a very basic level related to the nursing process. Those are my references, and so now I'd like to turn the program over to Danielle.
Thanks, Jennifer, for such a great presentation. Good afternoon. My name is Danielle Bowie. I am the System Director of Clinical Resource Management for Legacy Health, and I'm here today to present on Exploring the How, an overview of strategies used for successful workforce technology implementation to achieve data-driven workforce management. To begin, I would like to provide a contextual background and explain the environment of Legacy Health, where the implementation of the Workforce Healthcare Technology Project took place. Legacy Health is an integrated health system serving both Oregon and Washington state residents. Legacy has over $2 billion in revenue, over 13,000 employees, and 4,200 nurses. Legacy is comprised of 8 hospitals ranging from a level 1 trauma center to community-based hospitals. Annually, Legacy has 64,000 discharges, 290,000 ED visits, and 42,000 surgeries. In addition to the 8 hospitals, Legacy also has 108 ambulatory settings with 1.1 million ambulatory visits on an annual basis. Legacy also has joint ventures in urgent care settings, provides retail pharmacy services, has a cancer center, offers hospice services, has a research institute, and a health plan. The technology workforce journey for Legacy Health first began in 2014, when Legacy Health partnered with GE Healthcare for an enterprise conversion to an electronic time and attendance system for all Legacy employees. After TA was implemented, the Division of Nursing embarked upon a journey to convert to a new staffing and scheduling technology platform, inclusive of patient acuity and real-time business analytics. From a rigorous vetting process, Legacy selected GE because of its integrated approach with time and attendance platform. The workforce project started in the summer of 2016 and went through early summer of 2018. The technology applications listed on the screen were implemented in consecutive order. From June 2016 through October of 2017, staffing and scheduling was implemented for 126 inpatient nursing departments, totaling 5,000 end users. The implementation was completed in 4 waves, with each group having over 1,000 employees per wave. OpenShift notification was part of the staffing and scheduling technology conversion. During the rollout of staffing and scheduling, we also converted 3,500 end users to central recruitment from December of 2016 through August of 2017, using OpenShift notification in the staffing and scheduling platform. Mobile time management, which is the end user mobile app for both employees and managers for time and attendance and staffing and scheduling, was deployed to all Legacy Health in October of 2017. Business Analytics, a productivity tracking tool, was implemented for the Division of Nursing for 126 units by the end of May of 2018. Patient classification, a patient acuity system, is being implemented at the 8 hospitals for 46 inpatient nursing departments from March of 2018 through the end of the summer of 2018. Lastly, Attendance Plus is also being implemented by the end of the summer or early fall of 2018 and is a technology application to help with attendance tracking and monitoring for all of Legacy Health employees. Now that you understand Legacy Health's environment and the relationship between Legacy and GE, I would like to provide a brief overview on how Legacy used 6 strategies for successful implementation of integrated workforce technology. Though the 6 strategies are listed in consecutive order, there is the possibilities for the strategies to be completed simultaneously or have an overlap of information and timing. By way of explanation, the 6 strategies will be applied to the example of Legacy staffing and scheduling implementation, because it was a complex portion of the workforce project that had a significant impact on daily operations. But keep in mind that the strategies explained today can be used for any technology project. Strategy number 1, establish the project team. A project team with clear roles and responsibilities is foundational to the success of any project, and creating the team should be the first step. The project team for the staffing and scheduling implementation was layered and multifaceted for Legacy Health. There was an executive oversight committee, 4 end user work groups, and an actual project team. All of those teams were integrated through shared decision-making methods for optimal sharing of pertinent information. Strategy number 2, determine the how. It is important to determine how a project should be rolled out. To decide this, an assessment evaluating the span of the project, the size of the project team, and current staffing operations should be conducted. For Legacy Health, we approached the project as an enterprise system rollout to mirror our current staffing practices at the enterprise level, and deployed staffing and scheduling by specialty across the enterprise rather than bringing up one hospital at a time. For example, Legacy currently staffs all of critical care for the system at our 8 hospitals and does not staff hospital-based. Therefore, this guided how we implemented the staffing and scheduling technology. Strategy number 3, assess organizational structure. Assessment of organizational structure will help an organization determine the organizational readiness for technology change. For the assessment, role infrastructure should be evaluated to decide if you need to create new roles with different levels of access for the technology. This could include a scheduler, a staffer, a functional system administrator, a manager, or a charge nurse. From the assessment Legacy Health conducted, our project team, in collaboration with key stakeholders, restructured roles as well as staffing and scheduling policies to ensure organizational readiness for technology build and conversion. Strategy number 4, establish the timing. Timing is critical and essential for project success. A project too long or short can have negative ramifications on the organization. Therefore, the Legacy project team went to work building a very detailed project timeline to include in-person meetings, time for technology build, employee and manager training, go-live, and post-go-live meetings. Each activity was given a specific time frame for completion and a set of deadlines. Additionally, timing of go-live dates was critical and was designed to match organizational cadence related to publishing schedules. Legacy also strategically created a time gap between our first go-live, which was a pilot, to allow the project team the ability to assess the work and make any modifications to the project from the pilot group learnings. Strategy number 5, standardize documents. Standardization of activities and documents helps cut waste and rework for the project team. From our pilot group implementation, it was discovered that standard documents were really helpful. The project team therefore created standard documents to help support the work for the additional 3 waves related to the staffing and scheduling conversion. Those standard documents were shared electronically and in person with each end user. Strategy number 6, engage in before and after go-live support activities. Pre and post go-live activities are critical for end user adherence and were used by the project team to support the technology transition. At Legacy, more than 70 pre and post go-live meetings were led by the project team to support the transition. Those meetings were in person as well as via Skype and were spaced according to the go-live dates. There was also the use of a support email and 24/7 support from the Central Staffing Office to help end users with any questions. Even with the use of the 6 implementation strategies, the project team still faced internal and external barriers to implementation. The staffing and scheduling project covered every major holiday from December of 2016 through November of 2017. This required effort from the project team to be aware of training times, go-live dates, and holiday scheduling impacts. Additionally, during the project rollout, Legacy performed a complete system upgrade to the newest GE version. This required additional resources for the technical effort, organizational communication, and awareness of technology changes that had to be messaged back to end users. Upgrades during implementation is not a common occurrence, but had to be done to support all the other GE applications. To make it even more challenging, during the same time of the implementation and upgrade, Oregon was in the path of totality for the solar eclipse on 8/21/2017. This caused a 1 million person population increase during the week of the eclipse, which required additional work for the health system to be prepared for any type of emergency from the sudden influx of people. The Central Staffing Office was also operating in 2 staffing and scheduling technologies for over 7 months because we rolled out the technology per specialty across the system, which created a unique set of challenges, and every hospital had 2 different sets of technology for a period of time. Lastly, and sometimes the largest barrier for an organization, is an organizational history of past attempts of failed staffing and scheduling technology implementations. This created internal mindsets and a culture of resistance that the project team had to be cognizant of and use strategic PR and change management strategies to overcome. To deal with the barriers to implementation, we had key drivers of success to support the use of the 6 implementation strategies I talked about. First, it was critical to have strong leadership support and buy-in. The executive sponsor for the project was Carol Bradley, our system CNO for Legacy Health. This set the stage for the leadership engagement, and every level of leader was brought into the project, ranging from the system senior VP to the unit charge nurses. Engagement was achieved through face-to-face meetings, formal presentations, Q&A sessions, and extensive technology training. Due to the integration of the product, collaboration with functional partners was essential. Support with our HR partners, who were the operational owners of time and attendance, helped with an integrative build for staffing and scheduling. Partners such as payroll, finance, and IS were also key to the success of the project. The project team leadership was solid. Each team member had their defined roles and responsibilities. Within the project team, the defined roles included operational business owner, a project manager, functional system administrators, trainers, and the manager of the Central Staffing Office. Each person on the team had specific tasks assigned to their roles to create clear lines of accountability for optimal team functionality. User engagement methods focused on making sure we were connecting with what the end user truly desired, which was ease of use and at their fingertip experiences. To promote that type of access for scheduling, access was turned on from home and the mobile app was deployed. This meant that the employee and manager could view their schedule from their PC or their Mac. The project team also did a lot of demos to show the product and the functionality to support end user ease. We also had a separate email set up specifically for the project for employees and managers to send any questions to with a guaranteed response within 24 to 48 business hours. Lastly, we branded the project and wrote many internal communications from monthly newsletters to emails that could be shared broadly across the organization. The project was a huge success due to the use of the implementation strategies combined with the key drivers of success. Organizational outcomes for Legacy Health included adherence to a project timeline and being able to successfully meet every major milestone of the project that had been planned a year in advance. The project budget was maintained. Legacy also had high success rate of end user adherence. The use of a central staffing office required adherence, and units could not use other platforms or paper schedules. Additionally, we moved to central recruitment, which also enforced compliance with recruitment technology within the staffing and scheduling technology. In addition to the organizational project outcomes, we also had workforce metrics achieved that are being recognized as Legacy continues to use the workforce technology platform. Now that the departments of nursing are using the staffing and scheduling technology, there is a repository of information being coded into the system that allows our teams to begin to pull reports and provide analysis across the system pertaining to workforce metrics such as LOA rates, unfilled shifts, premium shifts, or departmental staffing patterns. This information will be used to assess an enterprise float pool to determine build and growth opportunities, but can also be used to assess at the unit level for operational improvement. Additionally, through the implementation of centralized recruitment platform from the staffing and scheduling technology, Legacy was able to reduce premium labor spend and ensure system adherence to the system pay practice policies. In FY18, Legacy Health recognized a cost savings of $115,000. Legacy also improved staffing and satisfaction scores for the whole division of nursing when comparing FY18 to FY17 scores, with 74% of the nursing units at Legacy Health rating above the national average for employees stating their work unit is adequately staffed. This is unprecedented, and considering the improvement was captured right after a year-long staffing and scheduling technology change related to recruitment. The workforce metrics mentioned are truly just the beginning stages of understanding the workforce outcomes from using the technology. And Legacy will have more metrics and outcomes in another year or so as we start to mine the data and further refine our systems for integration. I would describe Legacy Health as on a journey that doesn't end, but rather has continuous cycles of workforce improvement aided by technology for years to come. I would like to turn it over to Kathy Baker next.
Thank you, Danielle. I really appreciate that great presentation. And thank you so much for allowing me to be part of this webinar and allowing me to spend some time reviewing this important topic with you today. What I really hope to provide for you is an overview of how our team at VCU Health System in Richmond, Virginia, use technology to give nurses the tools they need to better manage and staff their units. VCU Health is a 770-bed academic medical center in Richmond, Virginia, and we believe in the importance of nursing and believe in empowering nurses. For us, and like most other healthcare organizations across the country, we need nurses in order to fulfill our mission and care for our patients. Attracting and retaining nurses is becoming even more challenging as the demand for nurses continues to rise. Projected growth of the RN profession is 16% from 2014 to 2024, which is more than twice the average growth rate for all occupations. The current shortage projections are due to shifting dynamics of healthcare delivery, reimbursement, and the aging population. There is also a change in our workforce dynamics. Stronger economy, more RNs are choosing part-time hours or retiring, there's changing workforce demographics, things are more mobile, and qualified applicants are still being turned away from nursing programs, primarily due to a shortage of nursing faculty. So for us at VCU Health, knowing that staffing is important to both patient outcomes and RN satisfaction, it was important to us to give RNs what they needed. We paid particular attention to the millennials. Now, I, like probably many of you, have attended many workshops focused on understanding the millennials, understanding how they need to be acclimated to the workforce. I've heard the same concerns that many of you probably have in regards to work ethic, their focus on the me generation. And so we began to look really critically at what millennials wanted in these changing times. And this is what we found out, is that number one, millennials really want to be valued and acknowledged for their contributions. They want their work to have meaning, and they want their managers to know them personally. They don't want to compromise in their own personal health and well-being. They're committed to their own health. And so as I reflected on this, what I realized is that the millennials really are my heroes. I want to be a millennial. The things that they want are the things that nurses should have always wanted. So we need to let go of some of our old traditional approaches to staffing and scheduling that have created burnout and frustration and embrace new ways of doing things. And what this means is we need to really ensure the work-life balance to our staff. It is critical to their job satisfaction and to their retention. And to realize that technology will play an important role as a means of communication and improving their workflow. So our staffing and scheduling plan is really embedded in our overall retention strategy, which is built on an evidence-based foundation of nurse empowerment, decentralization, and shared decision-making at the point of care. So staffing as our foundation, we know that the evidence is indisputable that adequate staffing improves patient outcomes. It reduces burnout and enhances job satisfaction. So our decentralized model looks like this. There is involvement at every level of nursing. Each unit has a unit-based committee that oversees their staffing and scheduling processes unique to their areas. Our overall staffing decisions, including our policies, our procedures, and really our guidelines and methodology, are owned by our staffing committees, which is made up of 50% of our staff nurses, or the committee is 50% staff nurse-led, and is part of our overall shared governance model. There are daily and weekly reviews of staffing by nurse leaders at all levels. Unit-based staffing is based on the outcomes and the evidence specific for those populations. And we do provide incentives for all shifts and weekend differentials for those shifts that are more difficult to staff and create more stress for our nurse staffing colleagues. We provide an internal agency, which gives us some flexibility in our staffing. And we use technology for real-time decision-making and predictive workforce planning. Now, this is really the key point, because we feel it is impossible to maintain our decentralized staffing decision-making model without real-time data. So from our staffing and scheduling system, we know this from really experience. Historically, our systems and work processes at VCU really struggle to efficiently support our decentralized staffing model. And we know this because our perceptions of staffing adequacy, when measured on our nurse staffing satisfaction score, were below the magnet means. We also knew this from a financial viewpoint, and that some of our divisions really struggle to manage staffing resources within their budget. And we know this by talking with our nurses. Many of them raised concern regarding excessive reassignment, and also often reassignment that they felt like was out of their competency. So with that, our nursing, staffing, and scheduling committee really took the bull by the horns, and they partnered with our IT and our finance staff members, and they developed an RFP for a staffing software solution that would fit their needs. The frontline staff really made the final decision on the purchase of the staffing and scheduling decision based on what would work for them. So the implementation of the new staffing and scheduling system was led by a frontline RN team. The staffing and scheduling committee introduced new workflows that enhanced capability of our system. It optimized the use of our supplemental staffing nurses to minimize reassignment of unit-based staff, and it created incentivized shifts to encourage self-directed floating. The staffing and scheduling committee, all along the way, managed this change process. They set the goals. They developed trust with our frontline teams by creating great transparency. They role model that the way that we wanted to manage staffing was through an organizational perspective. There was accountability built into the system for our nurse managers and peer-to-peer feedback to keep everybody on track. What we felt like we were able to do is really adopt best practices with scheduling now that we were able to have real-time data with our electronic system. With this, that also gave us an opportunity to have better role definition in the staffing and scheduling process between our nurse managers on call, and our staffing office, leading to a better work-life balance for all involved. Ultimately, we were able to leverage technology to meet the needs of all levels of nursing staff. So how are we doing? What we have been able to continue to demonstrate is really strong clinical outcomes. We have met and exceeded our goals in all critical nursing-sensitive indicators. Our HAPU in stage 2 greater pressure ulcers has been reduced to 1.09%. Our falls with injury per 1,000 patient days is 0.15. Our total infections per 1,000 patient days is down to 0.7. And with that, I'm not necessarily suggesting a causal relationship, but what I want to demonstrate is that you can achieve great clinical outcomes and still maintain a decentralized staffing model. And now for a more causal effect, what I can show you that we're extremely proud of is that all units at VCU Health have managed within their budgeted RN patient day for 2017 and year-to-date 2018. And most importantly, we've exceeded the magnet benchmark in terms of RN engagement around adequacy of resources and staffing. So I hope this will give you, some insights on how you can keep nurses empowered and managing their staffing processes within their own organization using technology. Now I'd like to turn it over to Carlene for her to wrap things up. Thank you so much.
Kathy, thank you much for sharing your experience at VCU. We have a fabulous cast of presenters here today who have done just an excellent job of being able to tell us about the scope and the future and where we need to be going. My job is to wrap up and talk about next steps. I am Carlene Kerfoot. I'm the Chief Nursing Officer for GE Healthcare Workforce Management Solutions. And it's my privilege to be able to say today that this is really an exciting time to be alive in healthcare. We can see the future coming together with the emphasis on data, on pushing data to make decisions and to use data to get to better outcomes than what we've had in the past. This is really the best of times, and I'm really looking forward to the next few months to be able to really implement all the wonderful things that you heard about today that tells us that data and outcomes go together, and we've got to really push that for our future. And the bottom line is over and over again that appropriate staffing is fundamental to safe healthcare. It's fundamental to everything that we do. So we are really in the best of times. This is really a good time to be able to implement all the things that we can do now. The bottom line that we've been talking about over and over again is that data can create safe outcomes. In the past, we've had the data, but we haven't utilized it. We've had the data and we didn't pay attention to it because we did opinion-based staffing. But now we have the opportunity of pulling it all together to create those safe outcomes. Dr. Mensick talked about starting with patient-centered, data-driven workforce management solutions. This should not be a novel idea, but in fact, much of our staffing is done by numbers, by census, and it just doesn't work, as she was able to explain so well, that the time has come for patient-centered, data-driven workforce management. And Dr. Boyd presented a very nice story about implementing a patient-centered, data-driven workforce management system that benefits, first of all, patients with safe care, patient satisfaction, and so on, staff with commitment, with engagement, with a feeling of safety, and also the organization in terms of outcomes. And finally, Dr. Baker made a very important point by saying that leveraging staffing technology is an investment, not a cost. And if we can pick up on that for our future, that staffing is not a cost. It is an investment in patient outcomes, in organizational outcomes, and in staff outcomes. It sincerely is an investment. So the bottom line that we really need to think about, that it's all about driving operations with outcomes. It's based on data, it's not opinion-based, and it provides terrific support for us to be able to do the kinds of things that we went into healthcare for in the first place, and that's to deliver excellence in patient care. I mentioned that there's a lot of data out there. Well, there is a lot of data out there. It comes from many different sources, many different sources. We've had it out there for many years, but we haven't been able to use it because we were not able to access the data from the right place. For example, we've had a lot of patient data in the electronic health record. We have spent lots of money, lots of investment in the electronic health record, and we haven't utilized it to pull out patient data that is indicated for excellence in staffing. We can do that now easily. We can go into the medical record and pull out appropriate patient and staffing information to be able to say, this is what this patient needs and this is what that patient needs. We also have the opportunity of looking at workforce data too, and looking at the ability to do different kinds of skills, scope, skill mix, outcomes, all that kind of stuff, because it's in our systems. And we know that the main reason that people leave is because of staffing. We know that equitable assignments is a real problem. So we have the opportunity now with the data that's in our workforce management systems to look at that and make better decisions about assignments to staff and patients, and also outcomes in terms of what we need to do 2 weeks out, 3 weeks out, 4 weeks out. And we also have to pay attention to the units, because units are different. Some have a lot more admission discharge transfers, some do not. In some units, the acuity is higher. They might have a lot of new nurses there. Units differ. And if we don't take that into account, then we won't be able to leverage the data appropriately and use it in terms of really good outcomes. Our vision is pretty simple. That the vision our speakers have presented is a vision that says that, first of all, a common consensus that appropriate patient-driven staffing is foundational to everything in healthcare will be developed. You really can't argue with that, right? That we really do believe that appropriate patient-driven staffing that's developed based on patient needs and not numbers and census and so on, is absolutely foundational to everything. We also believe that inappropriate staffing will be replaced by patient-centered data and evidence-driven staffing. And you can see that's beginning to happen now. We have the technology. We can utilize it in the best way possible so we can get there really quick. And third, that clinically intelligent staffing technologies will empower nurses to make their greatest contribution to patient care outcomes and financial and operation outcomes. People go into healthcare to take care of patients. They don't go into healthcare to take care of systems. And we have the opportunity now with intelligent staffing technologies to free people up to do the kinds of things that they need to do, which is take care of patients, with data that provides them excellence in terms of decision-making ability, because it's based on data. And finally, we know that appropriate staffing driven by data and intelligent staffing technologies will create happy patients, satisfied patients, happy families, satisfied families, caregivers that feel safe and empowered, and have a decent work-life balance, because we are able to forecast and do things much better than what we did before. So in summary, that's who we are, and that's what our vision is. But another point beyond that is that we have to remember that caregiving is really a compassionate profession. You can't be compassionate unless you have the appropriate staffing. So appropriate staffing is foundational to the ability to deliver compassionate care and do the kind of work that we went into healthcare for in the first place. So we do believe that appropriate data-driven staffing will ensure we can give our patients the compassion they deserve. You cannot be a compassionate caregiver if you don't have appropriate data-driven, evidence-driven staffing. So as we pull it all together, it's all about systems, it's all about compassion, and it's all about creating the kind of future that we want for our patients, for our mothers, for ourselves, for our communities, that creates safety and the feeling that we can do the kind of work that we were born to do. It's here, and we're busy to get it here as fast as possible. So may I now turn it over to Lily? And can you finish up from there, Lily? Thank you.
Thank you, Carlene. Let's move now to our question and answer segment, and I encourage you to send in your questions. And let's take a couple that have already come in to us. Kathy, I'll start with you. You talked about your staffing model. It's decentralized, so tell us a little bit more about how you provide coverage for difficult-to-cover shifts.
Thank you so much. We have been really able to improve our coverage for difficult shifts in really multiple ways. One, we're starting with more balanced schedules. And so we can really assure that we've got really good allocation evenly from our resources, so we're starting in a good place. There's less FTE leakage, and what I mean by that is that at times we know there are 36-hour employees that have signed up for 24 hours, or just you're not getting your weekend staff running their full complement of weekends. The system has double checks on that, so we really reduce that FTE leakage. By then putting our, really identifying our shifts where we need coverage more proactively, we're able to incentivize those shifts. So we push our resources to where we really need them. And then I think most important is that we're working always proactively. We can look in the system and project out, what our needs are going to be. And so we use a variety of methods to make sure, that we're not waiting to the last minute, that we're working to really make sure that we go into our scheduling period with adequate coverage. I hope that helps.
Oh, it does. It's great. The term less FTE leakage, I think, is very important. Danny, you work in a system at Legacy that has centralized staffing. Kathy just talked about their decentralized system. Tell us how your centralized staffing function works.
Thanks, Lily. I'm happy to. So for those of you that just saw the presentation, it wasn't fully explained in that presentation about how Legacy is structured in regards to an internal resource pool. We have 8 hospitals, and as a result, we have around 220 to 230 nurses of all specialty that are sent to each hospital based off of day of staffing needs. This is monitored through a central staffing office, which provides that staffing support to our 8 hospitals at a 24/7 basis. And so what we do is we engage charge nurses every day to understand their staffing needs. But prior to day of staffing, we actually centrally recruit using our open shift notification through the GE product. So we look at every single schedule, their core, and whether or not they are above or below core. We also take into consideration census, and then 7 days before the start of the shift, to align with our pay practice, we broadcast open shifts to the individuals who indicate themselves available, both at the unit level as well as at our resource pool, to open up extra shifts for those individuals who want to have the first claim. And then we look at 2 days to say, did we get our shifts covered throughout the system? And if we didn't, we'll re-recruit for those open shifts to a broader pool of people who are all qualified. And the way that we're able to determine if they're qualified is we used our staffing and scheduling technology to build in competency, qualification levels, so we filter effectively to target our message to the right audience. And we do this for about 60 nursing departments. We don't provide this service for our ORs quite yet, other than we just do day of allocation of our resource pool. But broader recruitment is something that we're working towards, just to take into consideration call schedules and specific skill set needs is something we're kind of working through. But I think the key thing here, whether it's central or decentralized, we also we have really strong forms of shared decision making. So we have work groups with members from each hospital and each specialty, as well as different roles that provide feedback to the leaders in charge of central staffing and recruiting to make the process smoother and ensure that we're really meeting end user needs, while also getting the right staff to the right location at the right time. And we have improved our staffing resources level of what employees believe their unit to be staffed has improved significantly since rolling out central recruitment.
So in addition, I agree with you, the shared decision-making being characteristic in both the centralized and decentralized, but in both centralized and decentralized systems, it does sound like the data tells you which shifts need to be incentivized proactively, and so you don't have that last-minute reactive trying to fill shifts. Very helpful. Danny, one more question. What reports are available to measure unfilled shifts? You know, because over time you want to find out what shift went without the staff that was needed. So do you have an unfilled shift report?
Well, there's a variety of different reports. So as I mentioned in the presentation, Legacy is still relatively new. We are less than a year out of having all of our departments or departments of nursing on a staffing and scheduling platform. So prior to implementation of this Centricity product, we actually had an Excel spreadsheet where our staffers, as I mentioned, we had that central staffing function. We were able to track unfilled shifts through Excel spreadsheets. There are different reports in Centricity where you're able to look at a schedule that's published and then whether or not that schedule, they're able to meet their core needs. In regards to day of staffing, we're still fine-tuning what reports we're able to pull out of our systems. And so, as I mentioned before, I think we're like in the infancy stages of true meaningful analytics, and I'm looking at bringing in individuals with skill sets with like SQL coding and the ability to pull data out of our system. So I apologize, this is a bit of a vague answer. We kind of are living with dual reports right now. We still are using Excel sheets and then measuring it against what's living in Centricity. And I suspect by the beginning of 2019, we'll have an automated report that will go to our system leadership to help with understanding where we're overstaffed and where we're understaffed, because that's the key, is ensuring that we have the right resource alignment. We don't want to cancel one day and then be understaffed the next day.
Exactly. Thank you so much for that clarification. I'd like to bring Jennifer into the conversation now and talk about the concept of missed nursing care. Many of you may have heard of missed nursing care that's listening to this webinar, a well-established, well-researched concept. So, Jennifer, talk a little bit about the liability for an organization that identifies those gaps in care called missed nursing care.
Thank you. So this is really important, and every organization and on every shift has missed care. Quite often, the nursing staff and managers will say, "Hey, we're short-staffed," but in turn, when we are short-staffed, no doubtably we are missing nursing care. And so, in most organizations, tend to not identify missed care unless there was a bad patient outcome or a near miss. And that's when we start to recognize that something wasn't done. And so, in a just culture organization, we look at those system issues to say what is going on with the process and with the way the care has been designed that could be leading, these system issues leading us to be missing care. And then how do we go back and redesign it, not waiting for a bad outcome to happen. So from a liability perspective, quite often we only look at those miscare issues when there is a bad patient outcome, instead of being much more proactive and saying, what does the care need to look like? What staffing and workforce do we need so we can ensure that we're not going to miss care on the unit? I know a few years ago we did a care delivery redesign, and we mapped out all the care that one nurse was doing on a 12-hour shift that would have been ideal, what we would have expected the nurse to do. And in a 12-hour shift, the nurse had 16 hours of work to do. And we know that isn't possible. We know that there's a lot of multitasking going on at the exact same time, but things do get reprioritized and things get dropped off that list. Some things get moved to the next shift. So of course it increases the length of stay, and things don't get passed and communicated. So it's really important for organizations to identify miscare, look at those care processes so that we can redesign the system before a near miss or before a bad patient outcome occurs.
Thank you. Absolutely great advice. Carlene, you talked a little bit about how these are data-driven staffing systems, but as you know, today opinion-based staffing is still frequently how hospitals staff based on not evidence-based, let's just say that. So how long do you think it's going to take before we really do see data-driven staffing replacing our current systems?
Well, I think there's sort of a tsunami out there with a lot of factors coming together that's going to push this faster than what has been done in the past. We've known about this kind of data-driven staffing for a long time but haven't implemented it. And some of the facts are, first of all, you know, the research that's becoming more and more plentiful. A lot of facts out there about how people in various organizations are much more effective with outcomes using data. And then also nationally, there's a lot of pressure out there from organizations to change the way we do things. For example, IHI has this thing about the joy of practice. And obviously you can't have the joy of practice if you don't have adequate staffing, appropriate staffing. AACN, the Critical Care Nursing Organization, at this last meeting, the president came up and said, we've got to do this. You know, we've got to change staffing. It's got to be patient-driven. We have to spend a whole, however many years it takes to get this done and to coordinate with all the people. And of course, ANA is really pushing with, they have a position paper out about RFPs for patient classification, and they've got another position paper. So there's a lot of forces out there that are pushing this. But I think the big force is reimbursement, because we know that organizations get paid less when they have poor outcomes. And we know that poor outcomes are tied to staffing. So over and over again now people are saying, oh, okay, I got the picture. I can't improve the outcomes and I can't improve my reimbursement until I look at how I'm doing staffing. So I think the time is come for all these different forces to come together to really make a difference in the next 2, 3, 4 years. And we will be able to move into real evidence-driven staffing versus opinion. So I think it's a great time. Super time.
It is a great time, and I absolutely agree with you, seeing all the forces that are coming together. There are a number of questions related to the cost of these data-driven staffing systems. Do you think they're prohibitive, or just talk a little bit about cost factors, and what do we need to be considering when?
Let me start with that, and then everybody else can fill in the blanks. You know, the systems, you have to look at the outcomes of the systems, because the outcomes, as you heard in this presentation, give you data, actionable data that you can work on. Also, the systems look at, you know, the amount of time it takes people to do staffing, so we can cut down the amount of time. So if you look at the outcomes, number 1, patient safety, number 2, staff satisfaction. And remember, staff satisfaction means turnover, and so turnover is very expensive. And number 3, just the ability to be able to connect with the patient and not pay the huge fines that we have. So there's a great ROI on all of this stuff, just a multiple forces ROI. Anybody else want to add to that?
And quickly.
I just want to add that, I mean, and really in terms of saving time, we have really seen the effects of that, and that the staff nurses have really enjoyed interacting with the system. So not only have we saved the time, we've increased their satisfaction with the process. So it's been good all the way around.
We're at the end of our time for today's webinar, and I'd like to thank Jennifer Mensick, Kathy Baker, Danielle Bowie, and Carlene Kerfoot for the powerful information they've shared with us today. Before you go, I have 2 important announcements for you. First, coming soon for you to use is a new resource called Best Practices for Workforce Management, a toolkit for CNOs. The topics covered in the toolkit include the importance of data-driven, patient-centered workforce management, making the business case, creating an effective workforce management system, and case studies of success stories that you'll want to read to use. And the expected release date is sometime in August. If you still have questions and we didn't get to that question, please send your question to Sophia Geller at American Nurse Today. You see her contact information on the slide. Or if you have additional questions, please contact her, and you see her phone number there. We hope you enjoyed today's webinar. And now, for all of us at American Nurse Today, thank you for joining us.